This surgectomy video is on esophageal atresia. To start off, I would like to define atresia. An atresia is a congenital defect that can occur anywhere in the GI tract. If we have a normal passage over here, food can flow freely from the proximal end to the distal end. In an atresia, we have either the absence of a bit of the passage or the abnormal narrowing of the passage. An esophageal atresia then would mean an interrupted esophagus. If we have the proximal esophagus over here and the distal esophagus, they do not meet, and food cannot get from the proximal esophagus to the distal esophagus or the stomach. This causes food to build up in the proximal esophagus, and when food builds up, it would overflow into the trachea. This is important because this is where the clinical symptoms will occur. There are several types of atresia. Type 3 atresia, also known as type C, is a tracheoesophageal fistula with a blind pouch. The reason I'm focusing on this is because it's clinically the most common and most likely to be tested. So here is the trachea, and here is a normal esophagus. They do not meet, and both are patent. In a type 3, we would have the proximal esophagus ending in a blind pouch. The trachea here on the left would abnormally form a connection with the distal esophagus. This over here is the abnormal connection and is known as a fistula. The Vactral association is an acronym for a set of defects which commonly occur with one another. The V stands for vertebral, and the defects included in this are hypoplastic vertebra, and this means an underdeveloped vertebra, or we can have a hemivertebra, and a hemivertebra is when half of the vertebra is missing. We diagnose this with an ultrasound. The A stands for anal, and this commonly includes an imperforated anus. We diagnose this with a physical examination. The C stands for cardiac, and defects include a VSD, ASD, or tetralogy of Fallot. We diagnose this with an echo. The T and the E stand for tracheoesophageal, and these include defects such as esophageal atresia. We will get onto the diagnosis. The R stands for renal, and we can have one or both kidneys missing. We diagnose this with an ultrasound or a voiding cystourethrogram. Limb defects are especially common, and these include polydactyly, which is when you have an extra digit, or syndactyly, when you have the webbing of the fingers. We diagnose this with a physical examination. Another common defect is thumb defects. Just to summarize, esophageal atresia is associated with other defects known as Vactral. We should be thinking about them after we have confirmed the diagnosis. So let's go back to the pathophysiology. We have the trachea here on the left, and we have the esophagus here on the right, which ends in a blind pouch. When food builds up, it eventually overflows into the trachea, and it causes cyanosis, drooling, choking, or in extreme cases, respiratory distress. To diagnose an esophageal atresia, we need to pass a nasogastric tube down the esophagus, and because we have a blind pouch, the nasogastric tube cannot go further, and we will not see it in the stomach. So let's look at this chest x-ray here on the left. We see the nasogastric tube, and it is nowhere near the stomach here on the bottom right. The first step in management of esophageal atresia is ensuring nothing by mouth, abbreviated commonly as NPO. As esophageal atresia is a surgical diagnosis, definitive treatment involves esophageal reconstruction with a primary repair reconnecting the ends of the esophagus. We place a temporary tube for patency and later remove it. The tracheoesophageal fistula, if present, must be severed. Prognosis is usually excellent, but patients often have complications like GERD. This video was esophageal atresia.